Welcome back, everyone. We're going to move on with chapter 12. This is our behavioral emergencies. We're going to start out by looking at the National EMS Education Standard competencies for this chapter. Medicine is recognize and manage life threats based on assessment findings of a patient with a medical emergency while awaiting emergency response. Psychiatric recognition of behaviors that pose a risk to the emergency medical responder, the patient, or others. We're going to talk about special patient populations, recognize and manage life threats based on simple assessment findings for a patient with special needs while awaiting additional emergency response. And then patients with special challenges, recognizing and reporting cases of abuse or neglect. So going into our introduction, emergency medical responders need to give psychological support as well as emergency medical care to our patients. This is where we're going to start talking a little bit about some of our therapeutic communications and being able to understand factors that contribute to behavioral changes, including some of those medical conditions, psychiatric traumas, mind-altering substances, or situational stresses. Our patient assessment for behavioral emergencies is the same as all of our other assessments. We're going to start with our scene size up, our 5,000-foot view, before we even approach the patient as we're coming on scene, looking around for any hazards or anything that we need to pay attention to. We're going to move into our primary assessment, looking for life threats and assessing our airway, breathing, and circulation. We're going to get a good, thorough history. We're going to go into our secondary assessment and continually reassess our patients. With our behavioral patients, it is extremely important that we are being very cautious and thorough as we're doing our scene size up, making sure that the scene is safe for us to approach. We want to make sure, we want to pay attention to if the patient is alert and oriented, if they're responsive to us, and then checking that airway, breathing, circulation, and getting our sample history. And remember, our sample history is signs and symptoms, our allergies, medications, pertinent past medical history, last oral intake, and any events that led up to them calling you for this emergency. Our secondary assessment is where we look to see if there are any other injuries or things that we need to focus on, where we're getting our set of vitals. And with these patients, a lot of our behavioral patients, we're going to want to move to that 15-minute reassessment as long as they are stable. If they're unstable, then we still need to remember that we're going to reassess and check their vitals every 5 minutes. But it can be overstimulating for a lot of our behavioral emergency patients if we are checking our vitals more often. So if we can, this is when we're going to be checking them every 15. Our behavioral emergencies are any situation where a person is exhibiting abnormal or unacceptable behavior that cannot be tolerated by the patient or by other people around them, their friends, their family, or the community. There are 5 main factors that contribute to behavioral changes. The first one is going to be medical conditions. And so we may see these in some of the things that we've already talked about in our medical chapters. But this could be uncontrolled diabetes, any respiratory condition, strokes. We can also see behavioral changes in head injury patients, patients that have infections leading to high fevers, or if they have excessively low body temperatures leading to hypothermia. The next thing that we could see is we could have physical trauma leading to behavioral changes. This could be head injuries or injuries that result in inadequate blood supply to the brain, resulting in shock. We can have psychiatric illnesses such as depression, panic, or psychotic behaviors. We can also have mind-altering substances like our alcohol abuse or chemical substances. The last one, and probably the most common of what we will see in some of our behavioral crises, are situational stressors. Whether this is the death of a loved one or a serious injury or illness to a loved one or the patient themselves. So what exactly is a situational crisis? This is any state of emotional upset or turmoil that causes them to move into a state where they can no longer control their emotions. It's normally caused by a sudden disruptive event. It can last. Normally, these situations only last for a short time, but they can cause unacceptable, self-destructive, or dangerous behaviors in our patients. There are 4 main emotional phases that we're going to see in situational crisis. And each patient may not have all of these, but they are likely to experience one or more of these phases. The first one is going to be our high anxiety or our emotional shock. We can have denial, anger, and then moving into remorse or grief. High anxiety or emotional shock, this is where our patients may have anger, normal signs of anger or irritation. They're going to have rapid breathing, rapid speech. They may be in an excited state where they have increased activity. They may start screaming or just appear agitated in general. This emotional shock is often a result of either a sudden illness or accident or even death of a loved one. It's often characterized by a cool, clammy skin, rapid pulses. You may even start to see, as they have this response, they'll start to get nauseous and vomit. And in general, they may just become inactive or show signs of weakness. The next stage that we might see is denial. This is where the patient or the bystanders are refusing to accept the fact that the event has occurred. Our response as emergency medical responders is to allow the patient to express that denial. We don't want to be arguing with them or pushing them, trying to get them to accept that. We just need to be understanding and work with them as they work through that emotional and psychological trauma that they have experienced. Some patients may skip denial altogether and move straight to anger, or sometimes anger will replace the denial as they move through these stages. Anger is a normal human response to any emotional overload or frustration. Sometimes the patients or the bystanders may start to vent that frustration or anger towards you. It's important that as emergency medical responders, we don't take that person's anger personally and allow it to build our anger and frustration. We need to be able to be calm, cool, and collected and help them as they process their anger and frustrations. We always need to remain professional and calm on the scene, and our professionalism and the calmness that we bring will help them to move into a state of calmness as well. As they have come to an acceptance of whatever has happened, you may find them in a state of grief or remorse. At this point, they may start to have feelings. At this point, they may start to be apologetic about their behavior and the fact that they have been angry and yelling and venting at you. We need to just, once again, remain calm and professional and be able to support them emotionally as they move through these stages. As we work through these stages, as we're working through crisis management on these scenes, it's important for us to remember that we need to do things in a systematic fashion, how we would on all of our calls. So we still go through the steps of performing our scene size up, performing our primary assessment, getting a good medical history, and then performing ongoing reassessment as we work with them and within our skill set and continue to provide reassessment for our patients. The most important skill and assessment tool that we really have in our toolbox is our ability to communicate and empathize is our ability to communicate and empathize with our patients or those on scene. As we communicate with them, as we are trying to create an atmosphere where they can trust us and feel comfortable with us, it's important that we pay attention to our body language. We want to make sure that we're introducing ourselves, getting down on their level, asking what we can do to help. Make sure that we're always being honest and caring and empathetic towards them. We don't ever want to be judgmental or put ourselves in a position where our body language or our actions or our words are making them feel uncomfortable. It's important that we always establish eye contact with our patients and try and remain calm and use a steady voice as we're talking with them, reassuring them and trying to get them to calm down. Try not to let those negative emotions and feelings and anger that the patient and bystanders have to interfere with your ability to remain calm and provide the care that they need. As we're communicating with our patients, it can be beneficial to rephrase the statements that those patients have using their own words and thoughts and being honest as we give them feedback, but also trying not to give them any false hope as we are talking with them. With that, it may be beneficial for us to maybe redirect the communication away from whatever is causing that situation and that anger and get them talking about different topics. As we're changing the topic or getting them redirected, it can also be beneficial to move them into a different location if that is what is causing the exaggerated stress response. Move them to a private, quiet area, and then be empathetic with them. Imagine yourself or your family member in that situation and try and understand if you were having those feelings, how would you want them, if you were having those feelings, how would you want the responders to treat you and to act? As we're doing our assessment on these patients, it's important to allow them to have the opportunity to talk, to give them the space needed to take the time and process their thoughts and be able to communicate clearly. As we're doing that, we want to be non-judgmental. Some of these behavioral issues can be very personal. It could be suicide attempt or other things. So we just want to make sure that we are not casting any judgment on them as we're allowing them that freedom to communicate with them. Always acknowledge the patient's feelings. Let them know that you hear what they're saying. If you can relate to it or at least empathize with those feelings. And then throughout the entire assessment, as you're allowing them that space to talk and explain themselves, then it gives us a good chance to assess the patient's mental status. Sometimes our communication with these patients can be hampered a little bit due to developmental disabilities. The CDC has indicated that 1 in 6 children has some type of developmental disability. So those disabilities can range from learning disabilities to developmental delays, can range from learning disabilities to developmental delays, and autism spectrum disorder. Patients with autism or on the autism spectrum may avoid eye contact with you. They may avoid eye contact with you as you're communicating with them. They may have difficulty expressing their needs using the typical words or motions that we may expect to see. They may appear to not even be aware of people talking around them or trying to give them directions. And they may prefer that they don't receive any physical contact, that you're not touching them or that you're not touching them or holding them or guiding them in any way with physical touch. We've talked about in other chapters how, as an emergency medical responder, it's important for us to be able to read the crowd and to know if the crowd is increasing the patient's anxiety and if we need to control that crowd by either moving them away or moving the patient away from the crowd. This is all part of our scene size up. And so if we notice something like that where the crowd is getting to be too much for the patient and their anxiety, we may need to request additional resources to help us to control the crowd and to assist our patient with whatever they have going on. Unfortunately, domestic violence is a common occurrence in today's world. We can see it in different forms. Some of the most common ones that we see are elder abuse, child abuse, and some of our domestic partner abuse situations. Whenever we are responding to a domestic call, we always want to make sure that we are remaining safe, but also that we are providing a safe situation for the patient whenever we arrive on scene. It's important that with all domestic calls, we understand that the patient assessment is the same. We provide good, effective assessment and treatment no matter what scenario we find ourselves in. But it's really important that we understand that this may be one of those required reporting situations. So we need to know what the requirements for reporting these domestic violence situations are in our state. We need to look and pay attention as we're doing our assessment for things such as broken bones or cuts. We may also see bruising in different stages of healing. You may see burns, scars from old injuries. If you see any of these things during your assessment that just don't feel like it fits, or if the story doesn't fit, then we need to make sure that we're documenting that and that we're reporting those things. We may not always see physical signs of domestic violence. Sometimes we would be seeing emotional symptoms of that, which could be exhibited through depression, suicide attempts, or even some of our drug and alcohol abuse. Abusers may be overly paranoid or sensitive and even threatening to you while you're on scene. So pay attention to the interactions that you have between your patient and other people on scene and the bystanders and the interactions they have with you, as these may be indicators that there is an abuse situation going on that they're just not talking about or that you haven't seen any physical evidence of yet. If you do suspect abuse, it is your responsibility to separate the patient from the abuser. Make sure that you remain open and non-judgmental, and then report that, making sure that law enforcement or whoever you need to call based on your jurisdiction has been called and alerted to the situation, and just making sure that you know those reporting requirements in your state. We often see cycles of this domestic violence where there's a tension phase where the abuser becomes angry and is blaming the victim. This is when the tensions start to rise. This is where the victim may even try to deny or minimize the violence from the abuser in this tension phase. As the tension rises, then it can move into the explosive phase where the abuser is actually losing control and where the abuser has actually lost control or the ability to think clearly. Most of the time, this is when injuries to the victim occur. The next cycle, or the next phase of that cycle, is going to be the makeup phase, where the abuser makes promises which are seldom kept. This phase is where the abuser is trying to keep the victim in the relationship as much as they can. As emergency medical responders, we may encounter any one of these stages of the abuse cycle. So it is important to anticipate the actions of both the abuser and the victim in all of these stages and be aware of the dynamics happening as we enter scenes so that we can recognize that there is a pattern of abuse happening. Sometimes we will be called to take care of violent patients. It's important that as we approach these patients, we establish verbal and eye contact as soon as possible. Check with bystanders to understand if they have a history of violence and what that history includes, whether it is physical violence or whether it's normally just yelling and verbal threats, and making sure that we are taking precautions to protect ourselves in those situations. As you're approaching these patients, as you're approaching these violent patients, you may notice signs such as them increasing the volume of their voice, yelling obscenities, bizarre speech. They may be pacing back and forth, unable to sit still, unwilling to let people into their personal space, protecting it and pushing people back. This can be because of this and their protection of their personal space. We always want to be careful of how we position ourselves around these patients. We never want to force a potentially violent patient into a corner. We don't want to allow ourselves to get into a corner. We never want to allow ourselves to get pushed into a corner or to allow our retreat to a safe area to be cut off. We always want to position ourselves as close to the door as we can, or whichever way we're going to have for our escape route. These scenes can become overly stimulating for our violent patients. So it's really important that you only have one person communicating with the patient. Make sure that everybody else is able to take a step back and try and have that one provider create the best rapport possible. I've been on scenes where I have been the one to initially approach and the rapport hasn't been there with that patient. And so I've been able to step back and allow somebody else to go in and start communicating with them and create rapport. And I've had it the opposite way where I've had to be the one to step in. So it may not be you that is the best option to communicate with that patient. Just know that you need to have additional resources, and if somebody else is there that can create a better rapport, then they need to be the one communicating with them. If all else fails and you're unable to create good rapport with them, if you're unable to get them to calm down, anticipate the need to have law enforcement intervene in that situation. And it's and with all of our calls, it's important that you have called early so that they can be en route, so that you're not waiting on them if you get on scene and you realize that it is escalated to a point where now you are in dire need of having that additional resource there. There has been kind of an increase in violence against emergency medical responders And part of that is because we work either alone or in such small numbers. We are working in environments where it is late at night or early in the morning. We are coming to these patients at the worst time that they have had. So it's not very often that we come across a patient that's having a true psychotic event, but they can be in this exaggerated, violent, anxious state just because of the other things that are going on. And because of the fact that we are only responding when they are in the worst time of their life, the worst scenarios that they have been put into, it puts us at a higher risk of violence. Because we are constantly responding to these type of calls, it's important that we remain vigilant and that we pay attention to calls that may have an even higher increased chance of violence. Some of those could be our crime scenes, anytime that you have gang involvement in your area, or any large group of hostile or potentially hostile people that have gathered, whether it be for demonstration or any other event. We can always minimize the risk of injury to violence. We can always minimize that risk of injury from violence by taking a step back, making sure that the scene is safe before we enter, making sure that we have a good escape route. This all starts from that scene size up, making sure that we have the resources we need prior to going in. Prevention is always the best. We don't want to put ourselves in a situation where we're at increased risk of violence. So be vigilant, make sure that you have an escape route, make sure that you're always thinking make sure that you're always thinking a few steps ahead, because any situation that we are called to has the potential of becoming a violent situation. Unless you are a law enforcement officer who is becoming an emergency medical responder, it is not our role to handle armed patients. At this time, we need to be alert to the situation. We need to recognize that they are armed, and we need to keep ourselves at a safe distance. If that's staying in our vehicle and waiting for law enforcement to arrive, then that's what we need to do. If we are confronted by somebody on the scene and we realize that they are armed, at that point we immediately need to attempt to withdraw or to leave the scene. It's important that we understand the medical legal issues that may arise from treating patients that are emotionally disturbed. If somebody that is emotionally disturbed agrees to be treated, then we don't really need to worry about legal issues. But if we find ourselves in a situation where that patient is refusing treatment, then we need to be able to, if we find ourselves in a situation where the patient is refusing treatment, we may end up in a situation where we have to treat them against their will. And it's important at that point that we have law enforcement involved in this, that we understand the rules and regulations in the jurisdictions that we're working so that we are protected. We must have a reasonable belief that that patient would either harm themselves or others before we go down that route of providing care against their will. If it comes to that point and we're providing care against their will, or we're trying to protect them or us, we may end up in a situation where we need to restrain the patient. And so there's a couple of things that we need to pay attention to if we're going to try and restrain patients. First is we need to understand their size and apparent strength, the type of abnormal behavior that they are exhibiting, and their mental state. And those things are going to help us determine the method of restraint that we need to use with these patients. Oftentimes, If we are trying to restrain patients, it may just be that we're holding their arms down, protecting ourselves. It may be that we have to step back. It may be that we need to get law enforcement involved to actually cuff them so that they're protecting, so that we are protected ourselves, but also protecting our patient and other people around us. If a violent situation escalates to the point where you need to defend yourself, you may use reasonable force to defend yourself from an attack. All the while, we need to be seeking assistance from law enforcement and making sure that we have those resources available so that they can protect us as well. In a lot of these violence or abuse related cases, we want to make sure that whenever possible, we have a caregiver of the same sex that is available to provide primary care for that patient. It's not always possible, but if you can, it is definitely beneficial, especially if it is an abuse or a sexual abuse case. Every year, thousands of people, from teenagers all the way up to elderly people, attempt suicide. And many people who fail their first attempt will try to commit suicide again. There's usually some underlying psychiatric disease that is treatable that has led them to this suicide attempt. As with all of our patients that are having any type of behavioral problem, we want to make sure that we're protecting ourselves and the patient from any further harm. We also need to determine whether or not the patient still has any weapons or drugs on or near them as we begin treatment on them. Our management of suicide attempt patients is going to be the exact same as any of our other patients. We're going to provide support for their airway, breathing, and circulation. We want to treat any open wounds. We want to remain non-judgmental, just remaining open and empathetic as we communicate with them, and then provide any emotional support as we're continuing our assessment and reassessment of these patients. Another common behavioral emergency that we might be called for is post-traumatic stress disorder. This is a mental health behavior that is normally triggered by some type of traumatic or terrifying event that they have either witnessed or experienced themselves. They may have intrusive memories of that event. They may have negative feelings or emotions, and sometimes there may be a trigger that actually causes them to feel like they are back in that situation. It's our job as emergency medical responders to protect the patient from any harm to themselves or to other people. Remember to remain calm, speak to them in a positive, supportive way, non-judgmental, and arrange transport for them to a medical facility. Mentioned sexual assault. With sexual assault, it is not only a physical thing, but we also have psychological aspects to the treatment that are very important. You may, in cases of sexual assault, delay some of your treatment until a responder or a provider of the same sex has arrived on scene, if possible. Your first priority in all of these cases, is to make sure that they are medically cared for as well as psychologically cared for. It's important that we remember sexual assault is a crime. This is one of those reportable things that we need to let law enforcement know about, or let the hospital or other EMS responders, as they're coming, know that this is what we let other EMS responders know that this is what we have going on. We want to make sure that we're not removing any clothing unless it's medically necessary. We need to try and keep the patient from using the bathroom or bathing in any way. That way we can keep as much evidence. That way we can keep as much evidence undisturbed as possible. We need to make sure that we need to make sure that our questioning is very comforting and calming, that we avoid like very fast-paced, aggressive questioning with these patients, and make sure that we are transporting them to the hospital so that they can receive the proper care that they need, all the while remaining empathetic and open with them as we are communicating with them. As emergency medical responders, you will encounter patients who are dying, whether that be from natural causes, accidental, or intentional. Whatever you do, we need to make sure that we are meeting the patient's medical needs and allowing them to work through those feelings of death. Your attempts to save or give comfort to these patients not only are going to help them, but they're also going to help the family and bystanders who may be around as they emotionally deal with the process of death and dying that they may be experiencing. Make sure that you're being considerate of the psychological needs of the patient and their family. Don't be afraid to Don't be afraid of touch. Don't be afraid of making positive statements as we're talking with these patients, but also don't give false hope. If they say, "Am I going to die?" we don't want to give them hope and say, "No, you're not going to die, you're going to live." We need to be open and honest with them throughout that communication. As emergency medical responders, we also need to be able to deal with our own work-related stress that we're going to, our own work-related stress that we're going to encounter just throughout the everyday of doing this job. If we allow stress to build in us without any healthy way of releasing that stress, it can begin to have negative effects on us. And as we talked about in the well-being chapter, we need to make sure that we are healthy enough that we can respond and take care of other people. Some of those signs of extreme stress that we may see in ourselves or in our coworkers are going to be depression, irritability, the inability to sleep, weight gain, weight loss, excessive alcohol consumption, or the inability to get along with friends and coworkers the way that we normally do. Most agencies are providing critical incident tests. Most agencies are providing critical incident stress debriefings after some of these incidents to make sure that we as providers are able to get together, talk with a trained, to get together and talk with somebody who is trained to help us process those feelings that we may have from being part of these critical, very stressful incidents. It's also important that if there is some type of peer support, that those members of your agency are properly trained and understand that all the communication that you have with them is confidential, and it's there for you to have somebody that understands what you're going through to reach out to and communicate with. And if you are somebody who has that ability to help others, then maybe become part of that peer support network at your agency so that you can help your coworkers work through the stresses that they see. The summary for this chapter: there's only a small percentage of patients that you're going to treat that have severe mental disturbance. There is only a small percentage of patients that you're going to treat who are actually severely mentally disturbed. But a lot of your patients, if not most of your patients, are going to be experiencing some degree of mental and emotional distress and crisis, which is why it's important for us to make sure that we understand and can recognize those behavioral emergencies within them. Behavioral emergencies are any situation where a person is exhibiting abnormal or unacceptable behavior that we cannot tolerate, either for safety for themselves or safety for the people around them or for us as providers. We had the 5 major factors causing behavioral crisis. They were medical conditions, physical trauma, psychiatric illness, mind-altering substances, and situational stresses. We also have our 4 emotional phases that we also have our 4 emotional phases to each crisis, which can be high anxiety, which can be high anxiety or emotional shock, denial, anger, and then remorse or grief. Your role as an emergency medical responder is going to be to understand the laws and regulations in your state or your community as it comes to treating and caring for patients that are in emotionally disturbed states, making sure that we are able to communicate effectively with them, be empathetic and understanding, but also able to protect them and ourselves as we're able to do that assessment and make sure that there are no other medical or trauma injuries that we need to be treating. Just remember, in all of these cases, ask yourself, how would I like to be treated if it were me in this situation? Making sure that we are remaining empathetic to our patients at all times. Our review questions for this chapter: number 1, behavioral emergencies are situations in which a person exhibits abnormal behavior that is deemed unacceptable by others, mild to moderate depression over a long period of time, anger that is justified by the situation, or strange behavior that is otherwise mentally stable. And the answer for this one is abnormal behaviors that is deemed unacceptable by others. Question 2, which of the following is not considered an emotional phase in a situational crisis? We have anger, denial, grief, or violence. And the answer for this one is violence. And our last question of this chapter: when treating a patient with PTSD, one of your responsibilities is to protect the patient from harm, speak with the patient in an authoritative, forceful way, convince the patient to take care of the problem himself or herself, or contact law enforcement immediately. And the answer for this one is going to be protect the patient from harm. All right, guys, that is the end of our behavioral emergency chapter. Doing great, moving right along. I'll see you in the next chapter.